Red eyes are either the result of inflammation of the ocular tissue or bleeding into the subconjunctival space. The pattern of the redness, nature of the discharge, associated pain, and its intensity, vision loss, and appearance of the cornea are helpful in characterizing the red eye. So, red eye is a potentially very serious condition, especially in situations where the redness is around the cornea. The causes are conjunctivitis, corneal ulcer, or keratitis, acute anterior uveitis, as inflammation of the uveal tract, acute angle closure glaucoma, uh, episcleritis, scleritis, and subconjunctival hemorrhage. So let's look at characterizing acute red eye with no history of injury. So we look at the diagnosis: predominant pattern of redness, the nature of discharge, vision loss, corneal appearance, and associated pain. So conjunctivitis, the predominant pattern of redness is palpebral, as inner lining of the eyelids. The nature of discharge is watery, mucoid, mucopurulent or purulent. Vision loss nil except when cornea is involved. The corneal appearance clear, may show punctate epithelial stains with fluorescence in keratoconjunctivitis, associated pain, nail to mouth pain. So corneal ulcer, predominant pattern of redness is around the cornea. Nature of discharge, watery or mucopurulent. Vision loss is variable. Corneal appearance, gray or grayish white patch when bacterial, fungal, or dendritic when herpes simplex is present. Associated pain, severe pain. So for acute anterior or uveitis, the predominant pattern of redness is around the cornea. Nature of discharge is watery. Vision loss is variable. Corneal appearance clear to hazy. Associated pain moderately severe. And for acute angle closure glaucoma, predominant pattern of redness around the cornea. Nature of discharge watery. Vision loss profound. Corneal appearance ununiformly hazy. Associated pain very severe. For episcleritis, the predominant pattern of redness is sectorial. The nature of discharge is nil or watery. Vision loss nil. Corneal appearance clear. Associated pain mild to severe. For scleritis, predominant pattern of redness sectorial. Nature of discharge nil or watery. Vision loss nil except when associated with uveitis. Corneal appearance clear. Associated pain very severe. So for subconjunctival hemorrhage, the predominant pattern of redness is sectorial. Nature of discharge nil. Vision loss nil. Corneal appearance clear. Associated pain nil. So let's look at a summary of the common types of conjunctivitis and their management. We'll look at the age and background of patients, the type of discharge, predominant type of ocular discomfort and duration, and also treatment. So bacterial for all ages, type of discharge purulent, predominant type of ocular discomfort, nail to mouth itching or pain, duration 1 to 2 weeks, treatment antibiotic eye drops. Viral for all ages, the type of discharge watery to mucopurulent, predominant type of ocular discomfort, nail to mouth itching or pain, and duration 1 to 8 weeks, treatment has to do with symptomatic treatment. So allergic for children and adolescents. The type of discharge, stringy mucoid, and predominant type of ocular discomfort, itching, duration, chronic, intermittent treatment, mast cell stabilizing agents, and sodium chromoglycate 2%, with trachoma, all ages associated with dirty, dry, dusty, poor environments. Type of discharge, mucopurulent. Predominant type of ocular discomfort is nil to mild itching or pain. Duration is 1 month to 1 year or more. The treatment is tetracycline eye ointment and azithromycin tablets. Now let's look at the WHO grading of trachoma. So 1 is TF, 2 is TI, 3 TS, 4 TT, and then 5 CO. So 1 TF is at least 5 follicles in the upper tarsal conjunctiva, which indicates active disease and need for treatment. 2 TI, that's intense inflammation. There's a need for urgent treatment. 3 TS, that's scarring stage, that's old infection, now inactive. 4 TT, that's trachoma trichiasis, as need for surgical treatment. And 4 and 5 CO, that's corneal opacities, visual loss from previous infection. Investigations: conjunctival swab for Cochrane sensitivity, purulent or mucopurulent discharge. The main treatment objectives are to treat the infection in the case of acute conjunctivitis, to relieve pain and refer immediately to the specialist for urgent management, to prevent blindness in the case of corneal ulcers, acute anterior uveitis, acute angle closure and glaucoma, episcleritis and scleritis. Non-pharmacological treatment for acute conjunctivitis: wipe discharges with tissue, discard it, and wash hands after each wipe. Don't share towels with others. Adults and children should avoid close contact with others. For example, from school, work, camp, and swimming. Pharmacological treatment. For treatment of acute conjunctivitis, first line treatment, you give tetracycline 1% ointment. You apply at night for 7 days, and chloramphenicol 0.9% eye drops, 1 drop 2 hourly for 48 hours. Then 1 drop 6 to 8 hourly for 7 days, or ciprofloxacin 0.3% eye drops, 1 to 2 drops 6 to 12 hours. So referral criteria: you refer corneal ulcers, acute anterior uveitis, acute angle closure glaucoma, episcleritis and scleritis immediately to the eye specialist, and also refer acute conjunctivitis which shows no improvement after 48 hours of treatment.